Hello friends, thank you for your timely coming. Thanks Samir for coming. And whatever, we are going to do this case under topical anesthesia. Okay. First thing, I don't have a digital caliper right now in my hand, but I have a normal caliper. I will just demonstrate the things with the normal caliper, and then the same way you have to take with the digital caliper. This is my normal caliper. Ask the patient to look into the center of a light and beta khali नको जाऊ तू, हाँ असंच थांब. And then take white to white from limbus to limbus at this location like this. Okay, you can see if you draw a line between these 2 points, the light exactly crossing that line means there is no parallax error. You should not watch from side views to take the readings. Here I can see it is around 10 point, this is 11.3 or 11.4 millimeter according to the manual. This thing, the digital caliper may vary a bit. So this is the way we are supposed to take the white to white diameters. It is always good idea to take it under the microscope. That will give you more precise reading. I am going to proceed for the surgery now. Usually take the 2 incisions, and this is the main port, a 2 planar incision. I am using 2.6 millimeter keratome, and now I am going to take 2 incisions which are side ports. While doing this, always be careful as you have anterior capsule which should not get damaged while doing this. If you are not confident, use the visco and do it. लाईट बघ बेटा, लाईट बघत राहा, इकडे तिकडे नको बघू. This much incision size will be enough. Now fill the AC with visco. I am using a low density viscoelastic. You can see a string of visco in the anterior chamber. That is called a string sign to check that the visco is optimally filled. It should not be overfilled. So once you have optimally filled it, you will see the strings which have come. IOL open please. Now the second step of the surgery is to load this IOL into the cartridge. For doing this is my cartridge. I am going to put amount of saline into it. Use more of a saline for IPCL implantation, and then a drop of visco just to lubricate it a bit more. First take the IPCL and place it on the cartridge. Now I am holding the cartridge in a way I am going to implant it. Okay, this is the right eye. I am going to implant it like this. So I am holding the cartridge in the same manner. Now once that is done, revert the IPCL. Put a drop of visco on the under surface on a concave side. That will prevent air bubble to get catched on it, and then place the IPCL correctly in a tunnel. Once you have put all the sides in a tunnel correctly, keep closing, and while closing also keep pushing the IOL a bit more. That should not get stuck between these flanges. Once this is done, use the forceps. Use a forceps like what we have, a pusher forceps, and check whether your IOL is moving freely or not. Here I can see my IOL is freely movable. Is it visible there? I am not sure of. Still, let me magnify it a bit more. Pusher forceps. Yeah, this is okay. Now see, once I am pushing the IOL inside, it is going nicely. Okay, fine. Now I am loading this into my injector system. Once this is loaded, check the IOL is freely moving. You can see the IOL is coming in front. Hold this. Our anterior chamber is not overfilled, it is optimally filled. I would like to fill it a bit more. Yeah, this is enough. Avoid having air bubbles into the anterior chamber. AC feel करावा लागेल अजून. Hold this. बेटा लाईट बघ गोपाल. सलाईन टाक कॉर्नियावर. हां, असं ठेवा नोट. Okay, that's all. I am getting some air bubbles into it. You should always avoid having this situation. I have injected my IPCL into the anterior chamber. Once that is done, push the amount of visco over the IOL. So much air bubble बेटा. visco थोड़ा push करून देशील ना. Once this step is done, I am having the dialer in hand. You can note two things. These two optic IOLs. Volt का. अच्छा. You can notice there are two holes. One is this one. Here you can see, which is at a haptic, and the leading haptic is having the hole on my superior side, on my left superior side. I'm just going to show you that. Sorry for those so much of air bubbles. You can note over here, right? And these two holes which are at the optic are superior. So I am going to tuck those haptics now. Light bug beta anvati ashi ठेव. Light bug. Centration proper. One, two. See, I am going to manipulate this plate haptic design as far possible from the haptic, because I should get enough play to manipulate it. I cannot arrange this haptic from here. I should go it from here only. Saline on cornea. Okay. Now I get more amount of space to do this. Pilo is ready, beta. Now my all haptics are under the iris. IA. Now I will go for IA. First I will remove these air bubbles. So you can notice all the haptics are inside, 1, 2 and these two also. So I will remove the whole of viscoelastic. While removing viscoelastic, keep the settings on a medium side, like 250 to 300 vacuum and 15 to 20 of flow rate. It should not be a very fast process, and use these holes to remove the viscoelastic under the IOL. You can go under IPCL also. There is no harm in doing that. But you need not necessarily in all cases you should do this. Okay. While doing this, your haptics may come out. This is a spherical IOL, so I don't have an issue with angulations. बस बेटा झाला है. त्याला थोडं रोटेट करावं लागेल. विस्को दे. थांबून जा. आइए. In case, as I am having right now the situation where my haptic has come out, if this type of things happen, always have your IA inside and then push the haptics in. That things will make it bit easier for me. But this is when you have done some cases, then only you should do this. Ideally it should be done only under the viscoelastic material. Pilo कर दें, air bubble दें. My haptic is still out. This particular patient was very much dilated, and that thing was causing a problem to me, as it was the haptic on temporal side was coming out. You can put a drop of air bubble in it and then do a head rope. That will keep the IOL pushed down. This particular IOL is always meant to be kept in a horizontal position. So you should manipulate it in a horizontal position so that your calculations and the type of IOL you have asked for, the model you have asked for, will match correctly. If you have kept the IOL vertically and the calculation was done when it was horizontal, you may have shallow angles the next day. त्याची काही गरज नाही. क्या म्हणते? Okay, this particular IOL is not having means the PI is not needed in most of the cases. This particular case was having ACD of 3.6 millimeters, so PI is not needed in this case. If at all PI is needed, you can do it pre-operatively with YAG machine. That is always good. In case you realize that the angles are very shallow at the end of the procedure, you can do a PI with vitrector or otherwise with a Vanna's scissor. As you can see, it is very well centered IOL with a small amount of air bubble in it. I draw. The case is nicely done. PI, I won't suggest in all cases. This IOL is having multiple holes and which do not warrant the need for a PI. I am having good formed anterior chamber and this is more than enough. Even though this air bubble is there, that is well and good. That will maintain its integrity, no problem. That's all. The first case is over. Thank you so much. The other I am going to do immediately. I usually put a drop of visco on the incisions. That will seal these incisions for a moment and prevent the saline from cul-de-sac to enter into the anterior chamber, and thereby prevent the risk of infection is less. I do it for my all cases, even though it is a phaco cases or all. Close beta, डोळा बंद कर. No, I have not seen any case of PCO in IPCL per se. Till now, we have done more than 50 cases and some of the centers additionally. So, even though after so many cases and more than 4 years of experience with IPCL, I am not have seen any case of PCO with IPCL. There is a chance that a retained viscoelastic material left behind the IOL will appear as a whitish material in the post-op period, but that will get washed away with a time, and that is not a part to be worried about actually. I was talking about the IOL rotation or a circular circumferential rotation of IOL while implantation. That is quite common thing, and but light मध्ये बघ बेटा. Give me main incision 2.6. Left hand instrument. Yeah. Many the times I use I need to give more time to my patient. He is a bit agitated as of now. When you implant IOL, there is rotation. Your hand may get rotated on one side, and that may cause IOL to be implanted upside down. Just take care for that always. गोपाल दोन्ही डोळे उघड आणि तू लाईटमध्ये बघ बरं बेटा. हां, लाईट कुठे आहे? हां, अगदी 2 मिनटं लागतील आपल्याला आता. IOL ओपन. गिव मी विस्को. Side port. I'll just take out these air bubbles so that the visibility should be good. I hope the centration is okay over there. I'm taking two side port incisions. One is superior, the other one inferior. This is the inferior one. Better look straight. Sarad bag. This is the superior one. Give me the IOL. Once this part is done, again I am holding my cartridge in a way I am supposed to implant the IOL. I am washing it with saline, more of a saline, and a bit of visco. I have taken this IOL over the cartridge, and now I am putting a drop of visco on the under surface to prevent air bubble to enter into the concavity of this IOL. Once this is done, I am placing the IOL in a way I am going to implant it. See the superior surface, this hole is now inferior and this hole is superior, the haptic holes, and two optic holes are on a superior side, as I am going to implant this IOL in this fashion only. So holding it in a fashion you are going to implant it helps a lot and prevents a lot of confusions. Now once that is done, I am going to keep pushing my IOL a bit and closing my flanges. Once this is done, give me pusher forceps. Yeah. With a pusher forceps, you can see clearly that the IOL is freely moving in the tunnel. Parakin. I have engaged the IOL in a cartridge. Parakin डाल दो थोड़ा और. Okay, fine. Okay, left hand instrument. Always keep your left hand instrument superior to the IOL to prevent damage to the endothelium while implantation. Now while implanting, what I mean is you should have the direction like this. You should not rotate it this way or that way. That may increase the risk for upside down implantation of IOL. See, the IOL is now very much rotated, like a circular fashion it is rotated, and it may open the other way. So I have to guide with my left hand and take care that it is not getting opened the other way around. Once it is in the anterior chamber, push amount of viscoelastic over the IOL, and now manipulate all the haptics into the anterior into the sulcus. बेटा लाइट बघत राहतो. पॅराकिन डाल दो थोड़ा. Now this one we are going to implant under this. Can manage because I have got enough space over here. This is done. The other way we will do for the superior centration नहीं. अब ये okay. If I magnify too much, the centration goes away. This is gone, and now this one is also gone inside. So all my 4 haptics are in. Make the IOL into proper position. Give me pilo, please. Before wash, I am going to put a bit of pilo because previously I was having issue of the IOL coming out while doing this. Yeah, the iris is bit constricted, so now there will be no issue while removing the visco. Now we have got a nicely IOL is set into the sulcus. Focus now is good. वैक्यूम अंकुश वैक्यूम कमी येतो आहे. ठीक आहे. ओके, गॉट इट. Remove the visco from these holes from under surface. Once this is done, job is done. Okay, now it is nicely cleaned. बेटा सरळ बघत राहतो. We are using a dispersive viscoelastic. Even though in case you left it a bit more behind, it will get washed away in next 2 days. That will give IOP elevation spikes in another 48 hours to you, but that will not be a problem. Do not undergo IOL to remove that visco if you are not confident, and you can just leave it. It will get washed away by aqueous mechanism in next 48 hours. That's all. Visco. AC is nicely formed. Antibiotic. Thank you so much for your presence. If there are any more questions, just 2 minutes, I'll be coming out.